Good morning.
Good morning.
Morning.
Howdy. Good morning. Morning.
Good morning.
Dr. Alsaati, do you want to start your laptop? I think your laptop is already open. I will let you share your screen.
All right, let's see. So I just click on share screen.
Yes.
All right. All right, do you see it?
Yes.
Okay. I haven't got the chance to review all the cases we're reviewing today, but we'll take it together then.
It would have been great if we got at least one sentence history, age of the patient.
I know, right? I mean, at least if it is a polyp, they could at least have told us that it is a polyp.
No, I mean, yeah, exactly. And the location. It
Yeah.
matters a lot, but I'll try to make some stuff up. Okay. All right. So whenever you guys are ready.
We are ready.
Oh, you're ready? Okay. And how many people is around?
We don't have a lot of people today right now. Let me message in the group. As soon as I message in the group, people will know that we have started.
Okay.
We started.
Quick question. Do you see all my screens or just the screen, just the path presenter?
If you want, you can have just the path presenter screen as well. When you share, just don't share the screen. Share the, like
the window,
yes,
a specific window. Okay.
Yeah.
No, I'm fine. It's fine. I just want to know what you guys can see. Anyway, so let's start case number 1. Obviously, just by looking at low power, this is a colon biopsy. What strikes me right away is the presence of the squamous epithelium. So I know right away that I am at the ano-columnar junction. Immediately my eye will jump at the squamous because the reason is with all the busyness of the columnar epithelium and the glandular epithelium, I might miss dysplasia in the squamous. So I immediately go there, I screen, I look, I find that there is nice maturation, and I move on. Okay, so I'm not too worried about the squamous epithelium, but I know that I gave it some time from my thoughts. Now I know where the pathology is. I have a colon biopsy. My crypts are a little bit distorted, and my eye falls on these. You guys see my pointer?
Yes, we do.
Okay, and my eye falls on these epithelial areas that are absent, which here and filled with some, possible granuloma. So look harder. Yes, I have an epithelioid granuloma here, and I look for more because the more the better. Obviously, my mind is going somewhere right now. I'm thinking of inflammatory bowel disease. I am favoring Crohn's disease. And there you go. You have one over here. You have another one. Very, very beautiful. This is the classic. It's called deep-seated granulomas, which are right here at the very base of the epithelium. When you have those granulomas a little bit more further up in the mucosa, they might be crypt rupture, they might be infection, but when they are very deep seated right here, they are classic for Crohn's. So you have a little bit of glandular disarray, you have basal cell lymphoplasmacytosis. Let's see, lots of plasma cells at the base of the crypts, right there. And then you have the granuloma. So my diagnosis is chronic colitis, comma. Let's see if there's activity. That's something I missed. I'm not sure if I found a lot of activity here. It's more of a chronic feature. Anyway, you have to look for neutrophils, but it depends on the activity. You will say whether or not there is activity. Oops, what happened? I don't know what I did. Oh, okay. Let's see. You will say whether or not there is activity. Then you would say granuloma, multiple epithelioid granuloma also present in the comment section. This is classic for, or this may be an infectious etiology. However, inflammatory bowel disease is favored, comma, Crohn's disease in particular. So this is how I would call it. So you have, when you go to the microscopic description, it does say transpleural inflammation with lymphoid aggregates, fissuring chronic mucosal injury, glandular disarray. Let's see where they, okay. Glandular disarray and granuloma formation. Just to be honest with you, I never signed out a granuloma without an AFB and GMS. So I always have to order that to make sure I'm not missing an infection, even when it's as classic as it is. And then let's see the differential. I would jump to the differential right away because this case is coming down our way later, but it's good to see them side by side. Of course, whenever you think, can someone mute?
I'm muting everyone, Dr. Alsaati, just a second. Okay.
Okay. When you are dealing with IBD, the two things that come to your mind are Crohn's and of course ulcerative colitis. So let's look at ulcerative colitis at this point. Full screen? Yes. Okay, full screen. Okay. So this is another colon. Obviously, this is to me, this is pretty much very, very chronic. You can see that almost from the extent of chronicity, you feel like you're looking at a small bowel biopsy, honestly. So this is how I see it. I look at it and I see there's so much villus formation and crypt distortion. Almost here, there's no crypt dropout. Look, see how the epithelium is so villus. When it reaches to that point, this is severe chronic colitis. And you have crypt dropout, you have basal lymphoplasmacytosis. Let me show you basal lymphoplasmacytosis. I think this is a good area here. Basal lymphoplasmacytosis. These are all plasma cells in the base of the crypts. Crypt distortion, and then you screen for granuloma. You don't see granuloma. And here you have a lot of small lymphoid aggregates. But what else do you see? Let's see here. I know I looked at this slide before. He does call this that there is a little bit of dysplasia at the surface epithelium. This is very ugly and I see mitosis, and the reason is I have to slightly agree is because I don't have neutrophils on the epithelium right here. I don't have neutrophils here. There might be some neutrophils in the lamina propria with granulation tissue, but to me this crypt in particular is not a surface, it's a base. If the epithelial atypia was at this area, I will call it focal atypia. But for me, this one is still a deep because you see how it's all rounded in. Okay, so now you can see the difference between Crohn's and ulcerative colitis. When do I make a difference? When do I call something Crohn's? When do I call something ulcerative colitis? Number one, if the patient has proper history and my slides match the diagnosis, I will say consistent with patient's history of Crohn's disease. Most of the time, I am more of a genetic. I will call IBD. and then I will favor one or the other. If I have skip lesions, if I have deep granulomas, I am much more comfortable. And if I have a diffuse process of ulcerative colitis, I'm also more comfortable calling this versus that. So again, it's all case by case. I know some people might ask me, when do you call this? When do you call that? It's really depending on the case. I will have a bigger picture when I see all the slides. If the patient has a terminal ileum and the rectum and everything in between, that's a classic for me to be more determined. Otherwise, not at all. You have to be descriptive. You have to be generic, because it's very critical that the patients at this point, innumerable times, patients were labeled as Crohn's for the longest time, and then down the line they discovered that it is ulcerative colitis and vice versa. So this is case 1. We're gonna move on. Let's see.
How often do you do CMV or HSV?
A lot. HSV only when I have squamous epithelium with pretty much bad ulceration. But I CMV, I do it a lot, especially first time diagnosis. First, I actually would never do IBD first time diagnosis without CMV ever in my whole life, because what if all this inflammation came back to be CMV related? Okay.
Yeah.
So what I do is, I had a case yesterday. My CMV was very funny. I could not match the CMV positivity with the epithelium on H&E. So I wasn't very sure. And I repeated the CMV, same thing. Focal, 2 strong cells that are positive, the rest are very patchy focal. Again, I could not match the cells. So I put it in my comment, say patchy non-specific CMV staining, comma, serologic correlation recommended. I want him to kind of think about it, because I couldn't make up my mind on my slide. And I also had 1 biopsy only. If I had several, I would have done it on all of them.
Okay.
Okay, so let's see. How do I leave? Hold on. Let me see. Let me go back. So, oops, I might need some help here.
So if you go to the third one, Pat presenter public, you might
Oh, okay.
go to the Pat
Yeah,
presenter
this
public, the fourth one.
Fourth one here. Yes.
Yeah.
Okay, let me then close these so I don't.
Yeah, that confused me.
Did I stop sharing?
Yes.
Yeah, and that's because I
Anyone else has any questions? Moin bhai? Okay. Seems like we're good.
Okay, I'm going to start my second case. Second case is about, okay, bread and butter of GI, basically, okay? So just by low power, I might be looking at a polyp of a colon. You go deeper and you go look further, and you see that you have a serrated polyp, okay? You see that serration. And then my eye at this point, okay, so now I have a serrated polyp. I look at the age of the patient, I look at the size of the polyp, okay? And to make up my mind, I wanna look at a nice looking gland that is touching the muscularis, so I can make up my mind and see the beautiful transverse growth, which is right here. Okay, you see that muscle right here, and then you have like this it's actually parallel. The growth is parallel to the muscle. So again, this is good for SSA. And what else? Let's see. Abortive crypts, you see this crypts that are growing right there alone. These are all more classic. And look at this. This looks more of a, this is the best. I think not a lot of us have problems with it. One hint for you guys, let's go to case info, see if they have. So this is, oh, that's the TSA.
Yeah, the location and everything too, like it's.
What do they call it? Where is it located?
Yeah, they didn't give us a location. That's what
Okay,
they should have.
no location. Okay, if that's a
Yeah,
cecum, I
yeah.
would definitely call this 100%.
Yeah, right. Yeah, exactly.
I'm not worried if this was, but again, it's not that pink. Usually TSA, I think there are better pictures than this for a TSA, in my opinion. I would not jump to call this TSA, but again, if this was a rectal biopsy or a sigmoid colon polyp, yeah, it's not too pink. I think he might have thought this is an SSA, but I don't know. Maybe we should email the author or something to give us more details. For those of you who do GI day and night and all the time, TSA should be very, very pink, very oxyntic, and you will have low-grade dysplasia. I'm trying to screen here. I can't see that. I don't see any kind of areas. So let's not waste our time on this one. I'm not too comfortable that this is the proper diagnosis for this case. Okay.
I'm gonna give this feedback to Dr. Singh that it would be great if we have at least the site of things, because
Yeah.
I mean, if the same thing is an ascending colon was the same thing in the rectum, it changes our thinking too.
Yeah. So actually, I'll tell you what. If that was this might cross my table many times, and I show it to my colleague, the difference between SSA and TSA. Honestly, location makes a huge difference for my
Right.
end of to call. But that area where he says there is serrated morphology of the crypts right here, yes, but I would love to have it more pink. I mean, there is more classic TSAs than this one. Okay, let's keep it
Right.
that. And then yeah, this is the ectopic crypt at the base. One more thing. All right, let's see now. Let me go back and
So if you want, you can quickly open a web pathology TSA and
okay.
maybe discuss those findings with us. Like the web pathology will have TSA, I would believe so.
Web pathology or even just Google, right? That
Even
works?
Google is fine. Yeah.
Okay. But if I open Google, the problem is, when that thing, when I want to close,
Or
close a bot.
check the differential diagnosis. They may have something there if it's empty.
So
or
I
not.
have a TSA in the web pathology.
Okay, can you share
and,
your screen then, and I will talk
Yeah,
about it.
yeah, sure. Let me go to Zoom. Host disabled by. Wait, I'll have to make myself host in my laptop. Host, yes. All right, so that's the web pathology. That's what they are showing in TSA.
Yeah, so it's a nice polyp. Let's move on to the H&E. Nice dye. So they place that dye and then they want to take it. Narrowband imaging of the same adenoma. Okay. Let's go back. Lots of growth.
Pedunculated villiform architecture.
Resembles TVA. Okay.
Here they are.
See, they see what I meant by it's not the most classic. The picture that we had earlier, it's so faint. It is so light. That's just a low power view. Guys, when you are on low power, you can do magic. Magic, I'm telling you. Low power view, you look at it, you know that this is dark and it is almost like an adenoma. And then you look closer and you see the cytoplasm. The cytoplasm is so pink and oxyntic, okay? Now you move on higher power, great. Yeah, you move higher power, it resembles adenoma, okay? Is that the last picture?
No, we have more.
Yeah, because I want to see the serration. I want to see classic serration. Look at that. Let's see. Yeah, what does it say here? Ectopic crypts. What does ectopic crypts means? That within the villus, you have small rounded small crypts, okay? We call it ectopic or abortive crypts. It's like little baby crypts growing inside the villus, Okay, let's move on. All right, more of these small, tiny ectopic crypts. And let's look, see how it looks like a TVA? Okay, so honestly, maybe once a day or once every 2 days, I have a polyp that I have to show it to my friend next door because I probably thought it's a TVA while it's an TSA. So this is not, here it says it might be mistaken for a tubulovillous adenoma, okay? So it's not something that we, it's not like really straightforward all of the time, but location is important. And just to let you know, management-wise, it's almost the same because these patients have to come after 3 years to do a screening. So in terms of management, it doesn't make a big difference. Look how beautiful serrated areas these are. Look how beautiful, beautiful serrated areas this is. It's very dark. The SSA is very light. Okay, now here, what do we have here? It's quite ugly. What does it say? Tall conversion. Cytologic, elongated with minimal cytologic atypia. Look at this beautiful mitosis in the middle. But again, I'm not gonna call this high-grade dysplasia or anything, okay? Yeah, this is mitotic figure, and it's a lot of pseudostratification, okay? All right, couple more. I think
we are fine with now.
This is, yeah, okay, we're done?
Yeah, I think like this might be some more dysplasia in the
Yeah,
TSA.
this is definitely high-grade dysplasia in it. Okay, let's move on.
Let me stop sharing. Yeah.
Yeah, I think that was great that we looked at a better example for TSA than the one we have there. Okay, so let me share now. I have to share, right? Okay, share screen, path presenter, and let's do case 3. Okay. For those who do general pathology, you know that this is a classic section for appendix, correct? So when you look at that, you have to see the tips, okay? And which is the one that my cursor on, this one and this one are transections of the tip. And then this is the margin, which is inked. And then these are just general lumen sections. Okay, let me go higher power. What do I look for in a tip? I look for carcinoid. And oops, there's something here, maybe a lymphoid aggregate. Let's see. All right, again, very important. In the tip, you look for carcinoid. And these are classic lymphoid aggregates in the tips. And then you have this growth here. This growth is pretty much at the serosal surface, not the mucosal surface. And there are glands. They do have some stroma around them. See that stroma? So you look carefully at the glands and you see that they have serrated epithelium. What comes to your mind is that patient is a female, and this is endometriosis, okay? Don't forget, look very closely inside the lumen. Look for mucinous neoplasia or mucinous differentiation or whatever disease that can come across your mind. Look at those lymphoid aggregates, make sure that they are not granulomas, and then look at your margin. This is just classic appendicitis. And then with endometriosis, let's see what they have here. Microscopic. So diagnosis is endometriosis of the appendix, ectopic endometrial glands and stroma, presence of cilia, and it may cause a stricture-like formation. Okay, we move on. Next case. close this.
There's also immunoprofile there.
Oh, there's also immunoprofile. Oh, perfect. So what do we do? Oh, perfect, perfect, perfect. So ER, PR, CK7, and it has to be negative for CDX2. I would definitely 100% do a CDX2 and a CK20. And it's not uncommon. I see it very often, by the way, endometriosis.
And it's not necessary that we have to do the stains if we are 100% sure of the diagnosis.
Yep. And I'm moving on.
Do you think you would want to do a CD10 if you are not having
Yeah. I mean, definitely want to highlight the stroma. Why not? It's very, it's not a here. When you look at endometriosis, you will say this is benign. You know what I mean? Like you will look at it and say, yeah, you know what? This is probably endometriosis. It's benign. Let me do this. Let me do that. What I do is definitely CDX2, okay? Because I don't want to miss a colon cancer that's there. That's funny. But for sure, once they are CDX2 positive, negative, I am more strongly supporting that this is just a classic endometriosis. But definitely, you can do CD10 for sure. Okay, let's see. Case info, where are we right now? The problem is I don't know where we are. Okay, yeah, perfect. I know where we are. So it's just a random colon biopsy, or they might call it colonic polyps, okay? Location doesn't matter, but you definitely, in that colon polyp, you have expansion, right? Once you look at the expansion, this is some serration here. It might be, here's the thing, it's very controversial. So just by looking at it, I'm telling you that this is a perineurioma, okay? There are two schools. They tell you that perineurioma, they occur in serrated polyps and hyperplastic polyps, or they tell you that perineurioma actually causes this crypt serration nearby, okay? So it's not like it was a polyp and now we have a perineurioma and next to it. So there are two schools. They always fight with each other. One tell you this versus that. Really doesn't matter. Benign, not important. However, if it is a classic SSA, then you call this cell serrated adenoma with perineurioma, or you call it perineuma with focal serrated glandular crypts. My thing is sometimes I completely don't call it. If I have a classic SSA, I don't even mention the presence of perineurioma. The reason is I will get a phone call from the clinician telling me, oh, what should I do? Oh, is this neurofibroma? Oh, is this malignant? Oh, well, it's just perineurioma, move on. But sometimes it's very difficult for them to wrap around the idea that this is a benign finding. Not very well, no, what I meant to say, if it's something that big, I would definitely do an S100. Okay, let's see the immunoprofile. I'll definitely S100. The reason why, I want to make sure it's not a mucosal Schwann cell hamartoma, okay? Classic mucosal Schwann cell hamartoma does not, I repeat, does not cause any crypt distortion like that. I mean, it's gonna cause expansion, but it really does not make the crypts more serration. It's not, it doesn't cause, it's not like within a hyperplastic or a serrated polyp. It's just like a normal crypt here with expansion. Let's see what they have here. Where's my differential case? Okay, this is the schwannoma. Let me show you side by side and sorry, not schwannoma, mucosal Schwann cell hamartoma. Okay, here you go. See, what I meant to say is your glands are not serrated. Look here. Okay, see how your glands is more like a hyperplastic change. Here your glands are pretty much bland, not serrated. And then you have a spindle cell proliferation here. And then you do an S100, these are all positive. And you do an EMA on the perineurioma and its focal patchy positivity. So these are the two that you keep in mind. When you see a spindle cell lesion or you see expansion of the lamina propria, go deeper, do S100 EMA, GLUT1, whatever you want to make your diagnosis. And so it's EMA. I don't have Cloudin in my practice, but I do have EMA and I have an S100. So these are the two. Very rare when it is much more spindly, I would do a DOG1 or a CD117 just to make sure I'm not missing a gist. Okay, but it's not the right location for it. So don't quote me for it. It's not the right location for gist. But what if it was deeper and it came upwards? Again, we deal with small biopsies, so you have to cover all your bases. All right, let's see how they described it. Benign, poorly circumscribed spindle cell proliferation, restricted to the lamina propria. The spindle cell proliferation may cause separation of the colonic crypts. Some examples are associated with serrated polyps, both serrated polyps and hyperplastic polyps. Okay, now we move on. And unless you guys have questions. All right, so this is another case. This is almost like omentum or something not related to the colon. It's not colonic epithelium. The beauty of this is if we have cytopathologists in the audience, they will have a smile on their faces right now because this is in the fat and it looks like epithelial or epithelioid or mesothelial or something. At this point, I have no clue. We have to rely on our stains, right? So let me see what they have in microscopic description. Pattern of epithelioid, most common, sarcomatoid, mixed epithelioid, papillary, tubular, diffuse, or deciduoid pattern, difficult to distinguish from an adenocarcinoma. Let's see, before I continue, this is positive for AE1, AE3, calretinin, WT1, CK56. So right now it's a giver that we're dealing with is the mesothelial lesion. It's negative for CDX2, CEA, and depending on what the location is, you will do, for instance, breast markers, you will do prostate markers, you'll do lung markers, and so forth. So again, it is a case of mesothelioma. Let's see if I was correct. Yes, malignant mesothelioma. And so this is just for your information, guys. Sarcomatoid looks like sarcoma, mixed epithelioid and sarcomatoid patterns also present. This precursors are asbestos, prior radiation, talc exposure, and these are all risk factors. Ultrastructural features are tall, thin microvilli on the cell surface, whose length exceeds the width of by a margin of 15:1 and are diagnostic for mesothelioma. Let's go higher power just to see if, no, I don't think this, this is only for the microvilli under the ultrastructures. Okay, moving on. I don't see it at all.
Does it have anything in the differential?
Oh, good. Thank you. Thank you. I always need somebody like you to remind me to look at all my stuff. Let's see. Differential.
Oops, sorry, it's not here. Okay.
It's not there, but I think they did mention it up here that the, oh, what am I? I'm not looking at the right case.
This is the endometriosis.
Yeah, okay, here. Let's see the differential. Differential definitely is carcinoma or reactive. Oh, they have a reactive.
Yeah.
Let's see. Oh, reactive mesothelial proliferation. It's too inflamed. Do you know how to get to that case or no?
The case on the left is the previous case.
No, to this case, to see the stains that they did, or
Oh no, there is no way.
okay. So here, the nice thing about this reactive, let's go to
Actually,
the-
click on the home button. Click on the home button over here on the right hand side. No, it doesn't. Okay.
Okay, let me show you something. So this is a 60 and this is a 60. I mean, obviously you can see there is little prominent nucleoli, less clearing of the cytoplasm, just unlike these cases on the left-hand side. I think the left-hand side is more atypical. Look how the nuclei and are very haphazard. There is almost not respect to each other. Over here, you feel like it's still sheets and rounding. I don't know. Reactive mesothelial versus malignant mesothelioma it might be sometimes very challenging in the cytology world. But for the most part, I feel like it's you have to take it case by case. Okay.
Any stains that would help to differentiate reactive and
Not in
no.
my, not
Yeah.
no, not in I mean, please, somebody
There
please
is,
gonna
you can
say.
do BAP1
What about
and
BAP1?
P16. BAP1 and P16.
Yeah, that
can
that
help.
is helpful in cytology. I don't know if it is helpful in histology. That we
No,
do in
loss
cytology.
Loss of BAP1 is for histology
Yes.
as well, right?
Histology too. I don't know. I mean, I
Okay.
have read it in cytology.
Yes, it is on histology too.
Okay, good, great. Thank you, girls.
so loss of BAF1 and P16.
Yes, they are in the same location.
Please, can you repeat the stains to differentiate both reactive versus neoplastic?
BAP1 and P16.
So loss of PAF1
Uh-huh.
Yes, and
and
P16.
and high P16 or loss of P16?
Loss of P16.
Loss of P16. Okay.
Okay. Okay.
In malignant mesothelioma.
All right. Thanks.
And
All
I
right.
think I mean, if you don't mind going back, I think the case 2 also had a differential diagnosis.
Yeah. Yeah, they did, and it was the reactive, right?
No, the case 2 of traditional serrated adenoma.
Oh, case 2. Oh. Okay. And case info and differential diagnosis. Yep, it's a serrated adenoma.
Thanks.
But yeah, I think we will just skip this for now. We will come to the SSA later to
Okay, that's fine too.
to read about it, to talk about it. Okay, because I didn't like this TSA in particular.
Okay. Okay.
I would suggest just keep on closing your tabs, otherwise you'll be.
Yeah, I'll tell you what my problem is. When I go up to close my tab, that bar.
Oh yeah,
for
that
the-
thing comes up. I know. Yeah.
comes down, so I stop sharing sometimes by accident.
You
and-
know, you can hide that bar as well.
Okay, let's see.
If you click on those dots and if you
I
hide
moved it down. I moved it down.
Okay,
I
cool.
moved it down, so now I can. Okay, perfect. All right.
And you can really hide it too, so it doesn't come in your way.
Okay.
Other guys won't know it because that is not visible to the other people, but it's
Yeah, it's a
annoying
pain. You
thing.
keep when I put my cursor up, it pops up and okay.
Yeah,
So
yeah.
case number 6 is the UC case. We have read about it a little bit. We talked about it in the differential, but let's talk about it even more. Let's give it more of it because I would say I have at least 3 a day. So it's not uncommon, okay, to see such cases. So when you look at low power, you see the colon is distorted, pretty much distorted. Again, I did say from the severe chronicity, it will look like a small bowel almost to you. And then your eye goes to see if there's any granulomas. This is the first thing I do, okay? It's not for looking for activity, it's looking for granuloma because it will change my thought process. So I screen very strongly for granulomas. I would go from one to the other. I look if there's any expansion here. Here it looks a little bit more pink to me. I go higher, but it's not. These are just dilated vessels and so forth. So you see what caught my eye? This hyalinization area here caught my eye for a granuloma. So you go down that area here, again, screen for the granuloma. This is catching my eye. I go higher. No, that's not a granuloma. I move on. Okay. So these are the things. While I am up there, I also screen for CMV. Okay. So that's my checklist, because I'm going higher power and I'm going higher power anyway. So so all of these are tricks to be faster and accurate and not to miss things. Okay. Because if I want to go high power for a CMV once, and then I go low power back, and then I go high power again to look for the granuloma, and I go low power back, and I go high power again to look for activity, and then I go power back. This is so time consuming for a pathologist. So at the same time, when I am on 20x, I have 3 things in my head. Okay. Just to make sure that I don't miss them. And I have to put them in my head. If I don't put them in my head, I miss them. Okay. Or actually, I feel like I did not give the case the proper attention. Even if I went high power to look for granuloma and I did not think of CMV, but I did not see it as well, I would actually go again on this case and go high power, because I feel like I did not give this patient the best of my thought process if I wasn't thinking, if I remembered later. Okay. So always don't forget your checklist. Okay. What else? So I wish he has some active inflammation that is pretty like, you know, crypt abscess and crypt what do you call it?
And our assessment is kind of limited here because we are kind of going fast. So even if present, we won't like quickly see it too.
Yeah, I'm sure. So active inflammation with ulceration, crypts, and crypt abscess. You know, he has not highlighted that.
Yeah,
So
so we
I'm
don't have.
assuming this is this case doesn't have activity, but you have architectural distortion, basal plasmacytosis, beautiful plasma cells. See them? These are all plasma cells at the bottom of the crypts. And you have focal surface dysplasia. Yeah, I did mention that. I would definitely make sure that it is a surface. This is, to me, a deep crypt, okay? All right, so let's see the differential. The differential, I'm pretty sure it's Crohn's disease. We already went through it before. And let's move on. Again, I would do a CMV if it was very active, okay? And number 7, case number 7 is what do we have here? What do we have here? We have colon. And so I think, ooh, beautiful, isn't it beautiful?
Oh yeah.
Okay. So what did my eye see? My eye saw all the colonic epithelia because that's where usually the pathology is, right? But screen very well and look for the bugs. And this is a beautiful worm. Okay, let's see his, oh no, I always like to look for eggs. Look at that.
Yeah,
look at that.
they're so good. I
Beautiful
mean, it's such
female.
a
They're
beautiful
really, really good. Yeah.
Isn't it just a
Side.
beautiful female? Okay, so Enteromobius vermicularis, that's the pinworm, and thick cuticle adult worms with characteristic lateral ali.
Yeah.
They have clicked on lateral ali. You can click on that.
Look at that.
That one.
Classic. Okay. And eggs are flattened on one side. Let's see the eggs again. Where is it? Wasn't it? There was an egg, right? We saw the eggs.
Yeah.
Oh, there it is. There it is. Yeah.
Yeah.
For those who are about to take the boards, I can't tell you how much the people who write the boards love bugs. So it will be there for your boards. See here, that's flattened on one side.
D-shaped.
I hope there is differential diagnosis. Sorry, I hope there is no differential. There is no, but trichuria is one of them.
Wish every case has as striking as this one.
Huh?
I know, right? She was saying that wish every case was as striking as this one.
Yeah, you're right. But the females are more open to the topic when we come to worms. The eggs give it away all the time. Okay, so let's see the next case. All right.
Don't worry about the time. If you want, we can have extra sessions. That's fine.
All right. So we have this beautiful colon. So this is, when I look at this, I know that these are not my cases. They don't come, I only see biopsies, but obviously this one is not a biopsy. This is a complete section showing the muscularis. And in the muscularis, you have kind of herniation of the epithelium downwards. So this is a nice case of a diverticulosis or diverticulum. And you have two side by side here, okay? I won't waste a lot of time on this one. It might be an appendix, I'm not sure because of the way it is here appearing, but it's okay. It's just a classic diverticulum, or I think it is. Let me look at the case info. I'm sorry, I didn't look at all the cases before we start. Oh, there you go. Diverticulosis with appendix, and this is outpouching of mucosa through the muscularis propria. And these, your eye has to go to the surrounding here, make sure you're not missing an endometriosis, you're not missing a mesothelial proliferation, you're not missing distant mets from patients with colonic cancer. So yeah, don't take simple cases lightly, okay? All right, so let's move on. Any differential? Nothing.
And it's
Okay.
my bad that you haven't seen the cases because I asked you the last
No,
moment
it's
that
okay, it's
do you
okay.
want to drive?
It's okay. It's fun. It's fun for me as well to go through them
Yeah,
like that blindly. I don't mind. All right,
Yeah.
another case. This is quite busy. Okay, so location is a stomach, right? And then we are I'm walking with you the way I actually screen my cases. Okay, so I have an antral biopsy here. It might have some reactive gastropathy on the top. See how there's corkscrewing of the antrum? Now I go higher, I make sure that there's no intestinal metaplasia piece by piece. I give every piece its due diligence, okay? I make sure that I'm not missing IM. I'm actually practicing my checklists with you guys. So if you want to see how I, sign my cases out.
Yeah.
So in reactive gastropathy, the muscularis, you see that muscle that I'm pointing at? It goes a little bit up to the epithelium. See it?
Yep.
Right.
Yeah. So that is also a nice classic case for reactive. I'm not sure what the diagnosis in this case is. I'll go ahead and see, but this is one thing that you want to keep in mind. Next is my next piece that has more auxentic or transitional type epithelium. Here, there's a lot of expansion. I'm not happy with what's happening here. I would definitely do a cytokeratin here to make sure that there's nothing creeping down here. Okay, but it could just be a funny cut, more auxentic. Nothing that bothers me here. And here's more auxentic. You go through it. You find that the surface is eroded here. Ulceration with erosion at the very top. Again, my eye is looking for signet rings and my eye is looking for what's going on here. That is pretty funny here. Okay, let's see what he wants us to go with. I will definitely do H. pylori. I'll do a keratin on this one, but this is just my way of dealing with things. Let's say what is it? Oh my God.
Really?
That the
See why you need to do a keratin?
Yeah.
Oh my God. Oh my God. Oh, my heart dropped. So here's the thing. I'll
This
show
is
you.
just very subtle.
Very subtle.
Yeah,
But
yeah.
I told you we have to do something here. Something is funny. It's very expanded.
Yeah.
Let's see what happens here. Let's see what did he say. Diffuse type, adhesive, plasmacytoid, eosinophilic, or signet ring cells, invasive growth pattern. Oh my gosh. Okay, girls, please. I told you 2 types of pathologists. I did mention that before, and I'm mentioning that again. And this needs a keratin. You can't do anything.
Well,
Wow.
you at least thought of it.
Yes, you did. Yeah.
You have to. Oh my God. I promise you, I have palpitations now so hard. Oh my God, I'm so happy that it's not a true case. Okay, but anyway, so it's you have
I mean,
to
you
think
should
about
be happy that it would have been a true case. You at least thought of it and you would have done the cytokeratin. I mean, think about some of us who might have not even have done it.
No.
It's,
Everybody, it's if look, I'll tell you what triggered me. You know what triggered me? What triggered me honestly is there shouldn't be any expansion on underneath. Okay,
Mhm.
that that subtlety in the base right here should not be there. You can't blame inflammation. You cannot and I'm telling you, this is not something that he was able to call without a keratin. I mean, he will be a fool if he called this without a keratin. It's nice that he picked it up, but you have to have a keratin to support it. I mean, what are
no, he cannot call it without keratin. He just didn't mention it, but he would have done it.
Definitely.
Yeah,
Look
yeah.
at these, and then you will see. Let's see if he has.
No,
If they don't mention the stains, that doesn't mean that they haven't done the stains.
Yeah.
That's not.
Yeah. Honestly, yeah. This is a very difficult case. Girls, stick this in your heads. I promise you, this is the nightmare of a GI pathologist. This one in particular. Okay.
Done.
But yeah.
Engrossed in my brain.
Okay. Yeah, please do that. It's look this. Yeah, we have to do a keratin. This is very ugly here. These are very ugly, very subtle. They look like inflammatory cells to you, don't they? They
Yeah,
look
exactly.
oh my gosh. Oh my gosh.
They can be easily mistaken for inflammatory cells or some artifact or
Yeah.
Agree with that. Yeah.
some smudge
Yeah.
nuclei.
No, yeah, but for sure, any site expansion in stomach, you have to rule out a cancer. Any slight, I don't care. What I would just do a keratin. Keratin is my best friend in GI pathology.
We could
You
have
have
just
to
leave it as a reactive gastropathy and move on to the next case. I
see,
don't know.
yeah, because this one, look at this. This one
Yeah.
probably
Yeah.
doesn't have it. This particular
Yeah.
piece is probably clean. I
Mhm.
mean, this particular piece is probably clean. I'm not
Yes,
sure that this
correct.
is involved. But again, this is just my eye here. But this one here, oh my gosh. Yeah, this one here should be a red flag, this area here. Didn't I go high and I was like, what's going on here?
Yep.
We sure
Correct.
have to do a keratin here.
Mhm,
But I
mhm.
couldn't point out the cells. I couldn't. It's just sometimes okay, my husband's right now is so involved in artificial intelligence and pathology.
Mhm.
And he's pretty much dealing with he's not a pathologist, he's a computer engineer, but he's dealing a lot with imaging and trying to have softwares that help pathologists kind of pick up subtleties in pathology.
That's a nice,
And
great combination.
exactly. So I told him that this is the classic use case. This is basically the classic use case for pathology. Let's screen every stomach in that comes our door for yeah, for carcinoma. Anyway, oh my gosh, nice case. Okay, move on. And which one now? Case number 10. What do I have here? Let's see. Case number 10 is a cross section. And obviously we have adenomatous change. And so this is my TSA, right? Or TVA. Let's see what they have it here.
Yeah, it does look like TVA.
It does look like TVA, but it also has look at these crypts at the base. Let's see what he calls it. Yeah, so he calls it TVA. Good. And the nice thing about TVA, so this is a resection specimen. It's not a biopsy. So low-grade dysplasia epithelium arranged in tubular and villus architecture, each component comprising at least 25% of the volume, can undergo high-grade dysplasia and intramucosal carcinoma. And the differential is a classic tubular adenoma, which is not villus. So why are we calling this villus? Look, you have all of these villus architecture coming through. I'm pointing with my finger. I forgot you guys can't see my finger here. And
no, we can see your pointer still.
No, I thought with my finger. I was like pointing on the screen with my on my laptop. And so you go, you see those villus formation. And when you're in doubt, just call it tubular villus. You'll get the patient sooner for
Screening, yeah.
For screening. And that's a regular tubular adenoma. Look how you don't have villus architecture. Okay, so here, lots of villi here, just classic flat. Not flat. I mean, it could be pedunculated, but it's not villus. Okay.
Yep.
Let's move on. Close this, and then we'll go to number 11. Oh my God, I think I'm going too slow. I'm sorry, girls. Let me.
And you know one thing I forgot to tell you. So on the right hand side, do you see those two arrows?
Right hand
on the
yes,
right
yes.
hand side top? So they take you to a different case.
Yes,
they take you to a different case.
The next case, basically.
Yeah, the next case, basically. Yeah.
All right. Okay, let's see. That's a nice case. So location is colon, gastric. Stop. Okay, where is my pathology here? Let's see the case info. Lipid lading histiocytes. Would you call this without?
It's not scanned very well. It's
yeah.
It's not,
but these are all almost like a xanthoma. Okay.
Yeah.
Gastric xanthoma. See it? But where was my eye first? My eye was looking for IM. Okay. So before doing anything, if I have IM in the epithelium, my xanthoma has to be ruled out because I need to do a keratin. Make sure these are not signet rings. Okay. So it makes me, I will not call a gastric xanthoma if I have IM without doing a keratin or a CD68. All right. So always, I don't see any IMs in this one. So I'm fine with it being a gastric xanthoma. Your differential, of course, is Whipple.
Oh, yeah, Whipple with the macro.
All right, it's loading. I had one Whipple disease in my ward, just one. Okay, it doesn't want to load. Well, we'll see it down the line, okay? So this is the gastric xanthoma. The differential diagnosis is Whipple, and there are no other differentials, but I would definitely do a on my day-to-day basis, I do a keratin and CD68 if I have IMs in the epithelium. Okay. Next.
They directly went to case 15, so that's not the right way to do it, then, obviously.
Okay, let me go 12. All right, another what? Appendix. No, that's not. So this is squamous epithelium, and you have glandular formation at the very bottom. It's that entity. Try to remember the name of that entity. Hydroadenoma papilliform. And it's benign, well circumscribed, dermal-based tumor occurring in perianal or vulvar region. Structures are two cell layered, inner columnar cell and outer cuboidal cell. See that? Outer cuboidal and inner columnar. And arranged in papillary form within the dermis. Apocrine features may be present. Most cases show no attachment to the overlying epidermis, okay? So that's very classic. I had one during my, a couple during my residency actually. But I don't get them here during my GI job because we only deal with small biopsies.
Yeah, I've seen them more often in the vulva and the axilla.
Do we have a differential? Okay.
We'll have to read the features of Syringocystadenomas papilliferum. This is derm.
Okay. Thank you for helping right there. Because derm for me is skin.
Exactly.
My diagnosis is skin.
Maybe the features. See the features. Click the features.
Okay, features.
Nothing.
It doesn't take me anywhere.
Okay, then yeah,
it's not working. Let me go back and see features. No, it doesn't take me anywhere.
Yeah.
Okay, I'll let the derm people present that later. Okay, moving on. Case number 13. Okay. Location is probably small bowel. Let's see if it's duodenum. I don't see it. Okay. Where is my eye going? So if we're looking at a small bowel biopsy, again, I told you my checklist is as follows. Let me go back. I want to see the other piece. Yeah, I can't call it duodenum because I don't see a nice Brenner's glands. So let's see. I don't have a lot of lymphocytes in the epithelium. Very subtle, whatever it is, unless we're looking at blunted villi here. Let's not waste time. Okay. Case info, microscopic description. Oh my God, didn't I tell you we're gonna miss it?
Out of all things.
So out of
It's
all
giardia.
things, yeah, that's why you have a checklist, girls. Look at the giardia all the way. Sai, right? You know, the one thing about giardia is the epithelium is so normal. The lamina propria is so normal. It cannot trigger you to look for it, you know? But there it is. It's all over the place. Oh, I'm so happy. Okay, so this is giardia. and they are all like flaky, like they look like almost like RBCs on the surface, but they're not red. That's how I see them. I see that they're squished, sickled RBCs without not being red. They call them the falling leaf pattern, luminal pearl shaped, and there is no differential. Okay.
Mhm.
All right.
How many of
Again.
you have seen cases of giardia in your practice?
Me?
No, you must have. Like I'm
A
talking
lot,
about
a lot, yes.
I mean, you must definitely have, but I'm talking about the other people. How many of you have caught giardia in your cases?
I've never seen one.
Yeah,
Neither me. Probably I would have missed also.
yeah, right, exactly.
Yeah, keep an eye on the leaves. Okay. All right. Is that colon with ulceration? More chronic features? No, 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 no. Take that back completely. So we have, we have gastric
Yeah.
with IM, extensive IM. And then we have ulceration. So we have to rule out H. pylori. Okay. So let's see. So that common is common, okay?
Mhm.
In my training, we trained to look for H. pylori on H&E. We never stained it.
Mhm.
You
Okay?
never stained it?
We never stained it in my training unless we really, really wanted
Oh.
to stain it. Yeah, I know. I did 4 years of looking for H. pylori on H&E. Isn't that fun?
Well, I mean,
Wow.
the H. pylori stain sometimes just picks out 1 or 2, and that is like you can't see that on your
Yeah,
just
yeah.
H&E.
So whenever you have very inflamed mucosa and you can't find it on H&E, we do the same for sure. But we have to look for it in our naked
In
eye.
the H&E.
Yeah.
Yeah. I mean,
So
if you see it on H&E, then it's clear you don't have to do the stains, but
exactly,
just
exactly. So malt lymphoma, how
that's a
about you
multiple.
girls deal with this?
Yeah, there is a small in the inside, like in the center fragment, there is a lot of lymphocytic inflammation,
Uh-huh.
and then there is this crypt architectural distortion. There is this like lymphocytes that are going into the epithelium too, if you see on the higher map.
Uh-huh. So you want me to look for lymphoepithelial lesions?
Yeah, lymphoepithelial lesions, then lymphocytes going into the epithelium too.
Yeah.
And then of course, like if you have like a lot of inflammation in the stomach or in anywhere, you have to look for
Now, do you
lymphoma.
call malt lymphoma if it's H. pylori, if you have actual H. pylori?
Yeah.
You do.
Yes, we'll do the CD20, CD3, and PAX5 stains, and we'll see the distribution if they're all B cells. And if they're all B cells and we have the lymphoepithelial lesions, then we know that we are dealing with lymphoma here.
And this is a lymphoepithelial lesion, right? Or no?
So lymphoepithelial lesion would be more of destroying the crypts. So if you
Okay.
go back to the middle of the section, this one,
Hold
the
on.
one on So
what am I doing? I made a line.
I didn't
Okay.
even knew that you can. Okay, you can clear it the line anyway. So yeah, so if you go over here, the one that is on the bottom, this one, so it's kind of the lymphocytes are going into the epithelium and they are kind of destroying the epithelium, like not on the bottom, this one, on the third one, on this one.
This
I'm
one? Oh,
pointing
here.
so there as well, and then on the left hand side, this one on left to that, so you see that it's kind of the lymphocytes are going into the epithelium and they are kind of destroying the epithelium on the left hand side.
Okay, is this
So
okay? That's fine. For me to find lymphoepithelial, oh, here you go. To find lymphoepithelial lesion, I will always do a keratin.
yeah, you can, yes.
I mean, just to my eye, I always struggles with that. But and then I send it to a hematopathologist nearby, and she
Yeah.
looks at it. But
And
for
then
the
over
most,
there as well, there in the bottom, and there as well, there is a lot of inflammation, like on the bottom right hand side, and then you might find lymphopathial lesions right there.
but I'll tell you what I do. What I do is I call this markedly inflamed gastric mucosa, H. pylori positive gastric mucosa. Not markedly inflamed, is H. pylori gastritis with
Marked chronic inflammation.
marked chronic inflammation, and then C note in my note, rebiopsy in 3 months or after treatment to rule out a lymphoproliferative disorder.
Right.
That's what I do. That's for the first time. And then the second time he comes back, it's very inflamed. That's when I send it to a hematologist. That's what I do is that a good practice, or should I do something else?
So, I mean, depending on how your suspicion level is, if you want to throw a CD3, CD20 stain in such kind of big inflammatory cases, it's not a bad idea.
And you
Just
shouldn't have any CD3? Or
so
minimum?
you should you should CD3 is for T cells and CD20 is for B cells, right? So you should, if it is a marked lymphoma, it is a small B cell lymphoma. So you should ideally all those reactive cells should be the T cells. So you should have the prominence of T cells with little B cells in that infiltrate.
Right.
But if you see that it is all B cells and it's prominently B cells and with the scattered reactive T cells, then you know that what you're dealing with.
Got it. Yeah. So when it is a B cell predominant, my suspicion for lymphoma has to be higher, and that's when I actually have to be. Yeah, I very, very frequently, of course, encounter that, but I also do CD43. And do you like it?
CD43 I would do after ruling out that they are B cells.
Yeah, I'll do 3, 20, and 43.
Right. Yeah, you can do that. Definitely.
Yeah. Okay.
Can I just add a little bit for that discussion?
Of course.
Yes. Yes.
Okay.
Please.
I'm also a hematopathologist by training, as well as in my practice. Very little of heme I'm doing, but more of general surgicals. So to convince the inflammatory process, whether we are missing sometimes the lymphoma, something like that. So if at all anything in basis of like underlying H. pylori associated gastritis, you are thinking of mild lymphomas. Even for mild lymphomas, first line will be to clear the H. pylori.
Yeah.
So if you are going to miss, if you are not extensively investigating for mild lymphoma the first time, it's okay. But also, again, it depends upon how much of lymphoid infiltrate is there. If it is predominant, then probably that will trigger for the workup, and you can label the patient as lymphoma. But again, if you are going to push it that lymphoma workup for a little bit and you are sure that the patient is going to come for a follow-up, then it is all right to push the workup for the lymphoma, and then you can say that this is what it's H. pylori associated gastritis, and then with whatever it is, and then the clinicians know what to do, because I am not sure how much other people will agree with me, but in my practice, if we are talking too much about, they say that, yeah, they even stop us in middle, and then they'll say that, yeah, I know the clinical management. So if you say that, okay, you follow up the patient and ask them to come after 3 months and all those things, probably they may or may not like, and again, you should know your clinicians, and some people will really like that kind of discussion, and some people may not. They will say that, I don't know. I feel that a lot of times the clinical team will feel that the pathologists are just pathologists. They are not physicians in their mind. I don't know what.
And sometimes they don't even like us recommending things because they say, okay, they are trying to teach us. So, I mean, yeah, that has happened.
My advice to every practicing pathologist out there, in my practice, I had invested so much to building great connection between me and the clinicians. I mean, my clinicians are only GI, gastroenterology. So it makes a huge difference. I text them, we talk all the time. I ask about their wives, their kids, and everything. I build very, very, very good connection with them for one reason. I want to be able to tell them, even if I can't put it in words in my report, I would want to talk with the phone on them and have an open conversation without restrictions about their patients. For instance, many times in lymphoma cases, I'll tell him, hey, Dr. So-and-so, I saw this biopsy today. Thank you for sending blah, blah, blah. Listen, treat her, bring her back in 3 months. It's just this random phone call between me and him. You know, it's not good. He's like, oh yeah, you know what? It was quite inflamed. I think it's just H. pylori. I said, oh yeah, I think so too. But just why don't you bring her back? I didn't say that in my report, for instance, but I also kind of triggered him to bring her back just with that phone call. I think connection between the clinician and the pathologist is very, very,
Yes.
very crucial. I wish
That's
they
true.
taught us that in residency. Every time in residency, I feel like they tell us that, you know what, just write it. Let's minimize phone calls. Let's minimize. It's not minimize. You're part of the team. You know what I mean? It's very important to get out there. I remember there was a blood banker, our clinician, Dr. Sandler, he was a blood banker. So I'm very talkative. I'm always jumping in the wards and walking around patients. So he would tell me, he would look at me, he would shake his head. He's like, I don't see you buried three levels under the ground with a microscope and a closed door. He keeps shaking his head. I'm like, don't worry, I will put my head out there. I'm not gonna be buried with my microscope. So needless to say, I mean, we're part of the team, so we need to show our faces. We need to be around. We don't be shy. I'm very, very open to talk to clinicians very frequently. So just a piece of
I
advice.
agree with that. I cannot agree more with that because
Yeah.
our hematopathologists, definitely they are like not only like buddies, but also like family friends almost.
Oh, see, that's
we
so nice.
know their families, we know everything. I mean, it's kind of the communication is the key over here. So
Yeah,
we need
yeah.
them to be open. We need us to be open.
Yeah, that's
So,
very true.
yeah.
Okay. Oh, let me can you move on just a second? I need to get my dog in. Hold on.
Hi, I just joined in. Today's session is 2 hours or 4 hours?
No, so today we can see how much Dr. Alsaati. I think Dr. Alsaati is available only till 12 EST.
Oh, okay. Okay.
So probably we are going to finish at 12.
Yeah. Yeah, I just joined in, but like in my 2 years of practice, I have raised suspicion for like malt, and 2 of the times I was right, and it like they had to if you raise a suspicion, I think like they follow up more diligently, and that's what we
Yeah.
want. Like otherwise with H. pylori, they just leave them sometimes. But if you raise a suspicion for malt, then they like, you know, are more diligent, and many a
I
times
mean,
we
being
lose
a
the patient in screening.
hematopathologist, right?
Pardon?
Being a hematopathologist, like if we see like prominent lymphoid aggregate, we start to get excited about those. So, but like not every not every general practitioner would think about heme all the time. We
I
tend to
think in
think of
GI
heme.
biopsies, like these biopsy, one is autoimmune gastritis and one is this mild lymphoma. These are the two easy miss outs.
Yeah,
So
agree.
I think like
Yes.
these two always like have in mind, like, and you will find it something. I haven't found autoimmune, but I have found mild only because I was looking for it, and like I
Right,
thought
exactly.
it could be there, and sometimes actually happens is like the tissue is so small you cannot do all the immunostain. So if you raise
Exactly. That
suspicion,
is
the next time when they come, they will do more, like give you more tissue, so you can like send it for PCR if needed, and then, you know, those kind of things.
Right, yeah.
Okay, I am back. So let's see what we have here. We have a stomach biopsy. And again, my eye is rolling for an IM. I don't see it.
It's very blue.
And say that again.
It's very blue. It's like in the video.
Yeah. There is some chronic
Okay.
inflammation. I don't have activity. I don't have, there is a vessel here, ectatic vessel, which is fine. I don't know what they want here. It's very superficial. So if there is okay, another ectatic vessel here, it's fine. Maybe the patient has cirrhosis or something. Okay, so I can't see anything other than these two things. So let me see what they want us to see here. And it doesn't look like an H. pylori. So vascular ectasia involving gastric antrum confined to the mucosa. It can have some hyalinization. There you go. Just gastric intervascular ectasia, nothing too serious. Maybe the patient has some portal hypertension or some cirrhosis, okay?
Yeah, the Gabe.
Yeah, the Gabe, right.
Yeah, so now moving on, next case, number 16. Oh my God, are these all eos?
Yeah, it looks like.
Oh my gosh, let's look for bugs. Anyway, but it doesn't have to. So this is a stomach. And when we're looking for eos in the stomach, to call this eosinophilic gastritis, you need to have eos in the muscularis, okay? And see right here, this is the muscle right here. And you have some eos here, okay? Eos here, eos here. I don't count them really, but it has to be expanded all the way down. And I think this is a nice classic case of it. I wonder what these are, you know, I've seen them on multiple, you know, this.
Is it some kind of bobble crab effect or something?
Yeah, no, it is probably
The gel they use for before doing the endoscopy.
Yeah.
Procedure.
For the tube.
either
For the
that
tube.
or either that, or if they have an automated embedder, then this is probably the plastic that they put on the blocks. I'm not sure, but I've seen like my eye had caught it. I thought it was an artifact the first second, but it's like the fifth case with this artifact on the side. Okay, anyway, so I would think that this is eosinophilic gastritis, but let's see what he thinks. Yep, and the features are greater than 30 eosinophils per high power field in 5 different fields. The overlying epithelium may show regular reactive regenerative changes. I would just add again that the eos should go very, very deep in the muscle, okay? These are the two things that you have to see.
I want to tell people here.
What do I do?
Sorry.
I do, huh?
No, go ahead, please.
I would do levels, okay? I would definitely make sure that I am not missing a granuloma. I would definitely make sure I'm not missing a bug. But otherwise, it's more strongly, I use it in colon biopsies and eosinophilic colon changes rather than the gastric. But for gastric, I will just be straightforward. And then my usual comment for this one is eosinophilic rich gastritis. And then in the comment section, this may be seen in patients. This may be labeled as eosinophilic gastritis. However, other differential diagnoses include food allergy, whatever that eosinophilia of the patient. I forgot the name of the eosinophilia.
Why do you look for granuloma? I mean, is there a specific association with eosinophil and granulomas?
No, I would definitely look for granuloma because I want to rule out infection. But yeah.
Sorry, rule out what?
Say that again. But infection, bugs. Okay. Yeah. And My eye caught something. I want to ask you guys, hematopathologist. I thought there was no, that's still muscle. Remember that little not amyloid, that little thing that comes from plasma cells. It's called wait, never mind. I'll remember it. I had one case. I'll remember it and I'll
Is
talk
it that
to you.
Russell body? Are you
Russell
talking
body,
about that?
yes. Yes.
Those has to be like diffuse, like those, the one you label at like Russell body gastritis, they have to be like diffuse and all throughout the biopsy, like all the plasma cell would look like that.
Yeah,
It's
yeah.
not like
But
focal or
this is
something.
probably is just muscle here, right? Muscle. I think
Yeah,
these
yeah,
are
yeah,
muscle.
definitely. Yeah, no.
Yeah. I had Russell body duodenitis.
Oh, wow.
Oh, wow.
Yeah, I had to
I
send
had a
it.
Langerhans cell histiocytosis in a duodenum biopsy. It was not my
Nice.
case, my colleague's case, but it was definitely that diagnosis. We had sent it out to confirm like what we saw is the same, and it was that.
Mhm.
Oh my
That's very
gosh.
nice.
I have one on my desk right now, and I will let you know, guys, what will it end up to be. It's a polyp of the colon, but it's all S100 positive. It doesn't look like granular cell tumor, so I'm sending it for CD1. I don't have a stain at home in house, so we'll see what it will turn out to be. Okay, so we'll move on from here.
So
And
before you say the next case, I want to tell everyone, if you go to the PAT presenter and you can search the cases based on the case diagnosis. So if you're reading a particular case, like particular diagnosis, and if you want to see a case of the diagnosis, you can just go ahead and search in PAT presenter. Just a small tip. Okay, go ahead.
okay, so this is another section of a colon, and then he is going high power here, and this looks like fat. Let's see what else. Ooh, medication, right? Fish.
Oh yeah, the cevilamide that the fish.
Mhm.
Yeah.
All right.
Excellent cevilamide, that thing, right?
Yes. So let's see. Let's see what he thinks. Yes,
Excellent.
coagulate injury. And
Excellent.
injury can range from mucosa to transmural necrosis. Crystals get embedded in the mucosa and causes ischemic injury. Crystals are refractile, appear purple, and have cracked appearance on H&E. Appear red on PISA. Okay. When you see that, I mean the classic fish, whatever
Okay,
flavor.
yeah.
Yeah.
Mhm.
What I do when I get such cases is I always ask for the history of the patient. I look for drugs, and if he has ICU admission, whatever, it makes me feel more comfortable. That calls it. I mean, I can pretty much name the drug at this point when it's like this. Also, if it's not shaped like this, it's very small calcifications. I have to rule out schistosomiasis. So, but this is not the case. Okay. So nice. Moving on. I like how he has a dot sign on his case.
I know.
All right, let's see where's the location. First of all, I think this is a gastric polyp. And then in gastric polyps, we have to make sure we're not dealing with dysplasia, or let's go to his dot. Oh man,
Maybe some dilated.
either that or gastric foveolar adenoma. Let's see what his diagnosis is. Pyloric gland adenoma. Okay, tightly packed tubules lined by pyloric type epithelium. Okay. Remember the pyloric gland metaplasia in the duodenum? Just imagine that with very tightly packed. Listen, pyloric gland adenoma is not an easy diagnosis, and it's not very common, honestly. When I have a pyloric gland adenoma, I show it all around to make sure, even if it was a straightforward case. It is not something that is, that it's not something that I see every day. Oh, there you go. Yeah, there you go. You might have some low-grade dysplasia here. So it tells you pyloric gland adenoma is a much more precursor. It's not like a Fundic gland polyp. It's more precursor for dysplasia. Okay.
What was he trying to dot? I mean, that dot
He's
made
trying
us
to dot
go-
dysplasia. I'm
Okay.
trying to see it right now. He's trying to dot dysplasia. Yeah.
But he didn't.
So
He
where do
didn't
you
underline it.
Huh?
So do you look at the epithelium again for dysplasia in pyloric gland adenoma?
Oh my God. Any polyp of a stomach, you will be surprised. You will be surprised how much the epithelium can show. Look, this is all adenoma here.
Mm-hmm.
Okay, this is all low-grade dysplasia.
Yeah.
So when you look at gastric polyps, honestly, when I first started the first year of my life in GI pathology, I used to run over gastric polyps very quickly, and then my colleagues said, you know what? Why don't we just spend more time on these epitheliums? And the more I look at it, the more I discover that there's a lot of low-grade that can occur in those polyps, even a simple Fundic gland polyp. So keep an eye on the surface epithelium, okay? Some of them are so big. I mean, have you looked at your hyperplastic polyps? Sometimes they can be 10 blocks, gastric hyperplastic polyps. But yeah, keep an eye on the epithelium. He's trying to dot dysplasia. Yeah, for sure. This one here is dysplasia in a pyloric gland adenoma. Okay.
So we know that tubular adenomas, all tubular adenomas have low-grade dysplasia. So is it expected finding in a pyloric gland adenoma as well?
No, pyloric gland adenoma, it's not expected finding, but it is highly, highly possible that the patient will have a low-grade dysplasia. So your pyloric gland adenoma line should be pyloric gland adenoma with focal low-grade dysplasia, period. Next line, no high-grade dysplasia present. Okay.
Correct. So that should have been here for this case also, right? With low-grade dysplasia.
Yeah, this is how it should be. It says with focal low-grade, no high-grade. Of course, you have to screen for high-grade. Very well.
Okay.
Dr. Alsaati, I have seen not more in the colon polyp rather than in the gastric polyp. Like there is some active inflammation, like there is active, like within the glands, there is like neutrophils, like cryptitis or those kind of things within the polyp. Do you separately mention them that there is?
No. If the line says it's a polyp, if the doctors say it's a polyp, I wouldn't. I wouldn't. Just call it tubular adenoma. It's very reasonable.
So I'll tell you my recent experience here.
Mm-hmm.
There was this endoscopic picture that had polyps in the ascending colon, and then there was some erythematous mucosa in the ascending colon. So I was trying to when I was trying to match the biopsies, the polyp that was thought to be polyp was actually erythematous area. And that's when the inflammation is important, not because on that particular biopsy, I was not seeing any feature of polyp. And then second, that was the hyperemic erythematous or what irregular area that they were seeing. So there was ascending colon separate polyp, and then there was another area which was having this feature. So how the history changes everything is very important. If you have a polyp in tubular adenoma or something, you'll very often see those acute inflammation. But if you see that acute inflammation, they have not mentioned as a polyp versus irregularity or something else, then those acute inflammation would be counted.
There is an immunoprofile and differential also for the gland adenoma.
Oh, perfect. Okay, MUC1 and MUC5A. I rarely do them. It's pretty much a diagnosis.
I don't even have them. I don't know if I have them.
It's pretty much a diagnosis of H&E. Fundic gland polyp. Just before we look at the fundic gland polyp, look at this. Look at the inside of your pyloric glands. And just keep an eye that the epithelium here is more of the pyloric gland epithelium. It's not the foveolar epithelium, okay? All right, and see, those are all pyloric glands. Now, if we look at the Fundic gland polyp, look at the difference. That's the lining is pretty much foveolar epithelium, okay? That's how you make the difference. Let me make this bigger. You can tell, right?
Yep.
Yeah.
Side by side, okay. And just to let you know that Fundic gland polyp is 1,000,000 times more common than pyloric gland.
Yep.
But it's more serious. The pyloric gland adenomas are more serious. Are we moving on to case number 19? Yes. Okay. Okay, case number 19. Another section of the colon. Trying to see what's going on. Pretty inflamed. I believe that this is just going to be some sort of hoping that's, wow, that's quite bad here, but it's too inflamed.
Yeah, I wonder if we want to rule out any invasion in there as well.
Let's see.
Around there.
Let's go with the microscopic. Dysplastic glands associated with invasion and accompanying desmoplastic reaction can be well to poorly differentiated. Okay, colonic adenocarcinoma. All right. Yeah, see this surface, how it's very, very dysplastic. And then you have all of that frowning and going off the glands. Look at this here. See how subtle it is? One would think that this is just like the diverticulosis, and it's very, very tricky.
Just the desmoplastic stroma, and then
yeah,
I don't know. I mean, I have seen when there is an invasion, there is more of you know, like the activity in the crypts, they increase much more. So that
right here, like
also,
that. Yeah. But this one here for sure, it looks like adenocarcinoma. Look at that.
Right. Yeah.
This is just completely adenocarcinoma. And remember yesterday, I know whoever was listening to the talk yesterday or the day before, I can't remember. I told you about the way that the edge of the invasion is, it's not rounded as much. Now look at this. This looks like it's completely rounded here, right? But look at this here. Look how they become pointy, growing inside. And this is all actually in the muscle. So anyway, this is all desmoplastic reaction, invasive adenocarcinoma. Okay. Immunoprofile, CK20, CDX2, negative for CK7, simple. And the differential diagnosis between this and adenoma. Well, I would definitely put a differential between this and pseudo-invasion. This is how I would look at it, you know, it's, but let's see, maybe he has something here. Yeah, he does. So, see, he does have something here. Trying to see. This is all hemosiderin-laden macrophages and some pseudo rupture. It's like ruptured crypts and deep-seated. Oh,
extracellular mucin.
Well, yeah, one thing that Montgomery taught me, okay, when you're looking at a pool of mucin that is sitting right there inside, in the middle of nowhere, okay, look at this pool of mucin and then look at the surface here. You have glands lining.
Yeah.
And you don't have glands lining. Look at that.
Yeah.
Then you're not dealing with true adenocarcinoma. This is just a You see what I mean? And she's
Mhm.
absolutely right.
Mhm.
Every time I have it, I screen all my lining.
Mhm.
I screen all my lining.
Wow.
She says, just go with it, go with this line and see if you have any. But look, I have a strips of mucin here. I have strips of glands here. I have them here. I have them here. But guess what? These
But
could
they
just
are
be
all
floaters and they could be detached from
Detached.
the surface.
detached.
There is
Yeah.
nothing, but you can have single cells here in the mucin as well. So don't be alarmed. If you don't have, sorry, if you don't have a lining of neoplastic cells here, then you're probably dealing with just a pool of mucin with
Extravasated mucin. Yeah.
okay.
Yeah.
That's just
What if you get the single cells? Will you still be thinking of it's not unless there is a lining?
I will
That's
go
what you're trying
deeper
to
and
say?
I will go deeper and see if my single cells reach the top.
Okay.
Okay. I always my and of course it's one of those cases that you have to show around and everything, but if you don't have high grade dysplasia up there, then you're less likely to have this as an injury. See what I mean?
Right.
Yeah.
Right.
Okay, so let's move on. But this is a nice case. This is pretty much what we see a lot of the times. Okay, case number 20. Okay, where are we? Oh, very dark. Squamous. So I think most of you will know the diagnosis in this one, right? It's our classic eosinophilic esophagitis. So eosinophilic rich esophagitis, if the patient has history, I'll call it consistent with patient's history of eosinophilic esophagitis. If the patient doesn't have history, I'll say see comment. In my comments, I would say increased eosinophils greater than whatever, or whatever, up to 100 per high power field. This given the patient's given the endoscopic impression of esophageal furrows. This is classic for eosinophilic esophagitis, period. However, this also can be seen in severe reflux esophagitis, if I'm talking about the GE junction, okay? So the reason I'm saying that, so what do I have here? The classic features for EE is, of course, increased EOs, spongiosis, and basal cell hyperplasia. So this is, let me show you one thing. I want a good, okay. So base and surface, these are the papillae, basal cell hyperplasia, spongiosis, and increased eosinophils, okay? So these are the three things that you have to keep in mind. And one other thing, you feel like you're looking at an immature esophagus. Do you guys see that? Like you're looking at an immature, like it's pretty much all of it is basal cells. You can't see nice maturity. And this has to be on low power, a trigger for you to look for EOs. And sometimes in early EE, you will have that and you won't have eosinophils, okay? You will have immaturity without EOs. And not infrequently, I would do mention that. I will say with marked spongiosis and basal cell hyperplasia, although reflux is favored, however, this can also be seen as early onset eosinophilic esophagitis. Recommend closer surveillance. That's it. Like, because I want the doctor to think, especially if the patient has dysphagia, he's 21, and it's not full-blown EE yet. Okay, so let's see case info, what happens. So EE and intraepithelial EOs, eosinophilic microabscesses formation, and reactive epithelial changes. With the microabscesses, and let's see the reactive epithelial changes. Yeah, it's quite nice. And there is nothing else you need to do here. Okay, and moving on, case number 21. Let me know when I need to stop. Okay, so
you need to stop when you feel like, whenever you feel like, when you are tired or if you have to go.
okay.
We are just the listeners. We are we are not the one who is talking. So if when
As
you are
long as
tired,
my kids are still sleeping and soccer is not until a couple of hours from now, I am fine. Okay, so we have a deposit here, right? It's colonic biopsy and we have a deposit of some sort. Oh, yeah, we have a deposit of some sort. How would you handle this case? What are the first stains that come
Mets,
to
are
your
you
mind?
thinking on Mets? Or is it lymph node? I mean, I don't know. It's hard to.
doesn't look like a lymph node.
Okay, then I would think
I
on
mean,
like
there's
anything
no
viscous
lymphoid cuff in
and
there.
coming
Huh?
from down.
Is
Or
it more,
neuroendocrine. Oh, it's
exactly, is it more salt peppery, you know?
Yes.
I would do CDX too, but I will also do those neuroendocrine stains.
Exactly, exactly. So we would start with synapto, chromo, right? And then we'll do a keratin. And let's see, I don't know, we're thinking together.
Would epithelioid just also be in the differential?
Not really. The location, yeah,
It's a
well, yeah, it
glomus.
is muscular. Glomus.
It's a glomus.
Well, it
Yeah.
says analogous to glomus.
Oh,
Analogous
it says
to
analogous to glomus.
So
Let's see what it says.
it is a
So it
glomus.
is glomus. Then why is it analogous to
Glomus tumor of the soft
the
tissue,
soft tissue.
monotonous appearing, hemangioperisitoma like vascular spaces. Yeah.
Yeah, it's very monotonous. But then, yeah, you definitely have to rule out the neuroendocrine for sure.
For sure. And typically seen in the gastric muscularis purpura. And immunoprofile. Let's see. SMA and calponin. And differential diagnosis, neuroendocrine.
There you go. Yeah.
Spot on.
There you go. And where is my neuroendocrine? Did you see the neuroendocrine? Oh, maybe the others. There you go.
There it is, yeah.
Okay. Well, that's a nice glomus tumor. See how it's very similar to neuroendocrine?
Yeah, exactly, right? Yeah, you have to do the stains. I'm not gonna diagnose a glomus without a stain.
Yeah, for sure. Okay. They are pretty much alike. Okay, so moving on to the next case. That's a nice refreshing to even my memory. I'm loving it. Okay, so
Dr. Alsaati, do you quickly want to take a 5 minutes break? Maybe just have some water and give
that's
everyone 5
fine.
minutes.
I'll make my coffee then, if you don't mind.
Yeah, exactly. That's what we would do. Like something to keep us going.
All right,
Okay.
I'll go get my coffee. I'll see you in 5.
All right. Yeah, sounds good. Okay. You guys also take a break. We'll meet in like maybe 11:50-ish after that.
Okay.
Looks like you're back, Dr. Alsaati.
Akanksha, where do we go in high yields to get these cases? Like what?
So you just
like
go to pathpresenter.net and you
Mhm.
have multiple like small windows over there, and you just there is one that says high yield cases. So you
Mhm.
click on that, and it will lead you to all the organ systems, and just like that.
Okay.
Dr. Alsaati, are you talking?
Yes, now I am back. I have been muted. So, oh my gosh, I feel so stupid. Okay, anyway, so now we're looking at a polyp. It's probably on the right side of the colon, let's say. you screen right on the low power, you see that we're looking at a serrated polyp with the base of the serration is wider than the top. If you look, here's what I do is I look at this crypt and I see the top is narrow and the bottom is wide. Okay. Of course, you don't need to do that, but sometimes when you have only a very small biopsy and probably just the side of it shows serration, you might want to do this criteria to see that the bottom is wider than the top. Okay, and for the most part, there's another one. There's the bottom and here's the top. And here's the bottom and here is the top. Anyway, so this looks like a sessile serrated adenoma. The next thing I do when I see sessile serrated adenoma is I look for dysplasia. So before they used to differentiate, why am I not able to make it larger? Differentiate between low grade and high grade. I will call this with dysplasia. Okay. But this is not high grade dysplasia.
Your
So there are
voice
two.
is breaking.
Huh? Say
Your
that
voice
again?
was
is coming
breaking.
from distant, like previously it was very clear. You
Okay,
might
should I exit and come in again?
I can hear you well.
maybe or see if you are in speaker or something.
Yeah, I can hear you well as well.
I can't hear you actually well, Akansha.
Yeah,
Okay, then
Akansha
go
seems to
back
be in
and
a
come back.
distant.
I do.
Did you
Yes.
change anything? Yeah.
Do you have headphones?
Yeah, I do have headphones.
Now we can hear you better.
Okay, let's do like this.
Okay. So before they used to call this sessile serrated adenoma with low grade dysplasia. Right now, they only call it sessile serrated adenoma with dysplasia. They don't differentiate low versus high. This is the latest SSA upgrades.
Why is that?
Because there's no difference in prognosis. When you have
Okay.
dysplasia in SSA,
Mm-hmm.
whether it's low or high, you have
Okay.
to treat it similarly.
Okay, that's good.
Okay. So it's very important to look for dysplasia. Me in particular, I do mention still whether it's low or high, but it's not the latest recommendations. Okay. So let's see. So they will call this sessile serrated adenoma polyp or adenoma. Differential diagnosis is a TSA, and the differential diagnosis is a regular tubular adenoma, and I think you can tell the difference here. And it's nice that they gave you the adenoma at the probably ileocecal valve or somewhere, because let's see, there's like a small bowel here, mucosa. So it's good because they want to tell you that based on the location. I really like this slide because he's telling you that don't get fooled. These are not serration on the side. This is normal histology of the junctional mucosa, and you're having a tubular adenoma here, okay? So, and he has one here transverse. See that? But this is not an SSA. This is a normal crypt based on the location of this adenoma. That's a very, very nice case to compare it to. Okay, moving on. Next case is case number 23.
Have you ever seen signet ring cells in a tubular adenoma or any serrated adenomas or polyps?
I haven't. No, I haven't seen a signet ring before in a, you mean in colon, right?
In polyps, yeah, in the colon.
Colon polyps. No, I haven't. I have seen carcinoids.
Okay.
They're incidental, but I haven't seen signet ring.
Okay.
I have seen signet ring carcinoma in a Fundic gland polyp of a stomach.
Oh, wow.
I know. I promise you, I know. I sent it to Stanford. But yeah, so it was very challenging. Okay, the other one is, this one is, let's say, it's another polypoid lesion of the colon. And we have expansion here. Hyperepithelial, inflammatory, let's see. Overlying epithelium ulceration. So this is solitary rectal ulcer. So again, location. I mean, seriously, come on. I just need the location of the polyp. It would have been much more helpful.
Exactly.
So let's see the classic features of a solitary rectal ulcer. Overlying epithelium ulceration.
Just a second, let me mute everyone. There is someone who's getting a call.
Yeah.
Mute.
Overlying epithelium may show ulceration and erosion, reactive epithelial changes. The lamina propria show fibromuscular hyperplasia. So solitary rectal ulcer syndrome is not always an ulcer, okay? Solitary rectal ulcer syndrome has a different name as well. It's called mucosal prolapse, okay? So my diagnosis for solitary rectal ulcer will always have / mucosal prolapse, because what it means the muscularis at the base of that area in the rectum got expanded, got thickened, and got pulled all the way to the surface. Okay? So muscle can give you a lot of answer. Look how thickened it is, and it's pulling all the way into the surface. Look at that. Okay? And it's not always ulcer. Be careful. The surface is not always ulcerated. Okay? So when you don't have that classic ulceration for your surface, you will always say you'll say solitary rectal ulcer / mucosal prolapse. And it's pretty much very common. Look at this here. This is the best. This is the best. You see the base here, the muscularis should be here, and it gets all the way thickened between the glands. You shouldn't see muscle between the glands at all. Look at it. It's going all the way to the surface. See that? Okay, so this is solitary rectal ulcer. Fibromuscular hyperplasia is your classic. Okay?
Dr. Alsaati, was there a hyperplasia of the glands, like some hyperplastic changes? Would you ignore it in the presence of prolapse?
I would completely ignore it. First of all, for two reasons. Rectal mucosa, by definition, will have normal histology of mild hyperplasia. Okay, so that's just by default. If you go to histology for pathologists, you'll see that the crypts of on the glands of the rectum are more hyperplastic. Okay, so if the doctor calls this a polyp and you see mild hyperplastic change in the rectum, don't call it hyperplastic polyp. What I would say is I would go deeper. I will say surface mild hyperplastic change. And then in my comment, I would say, if let's say he saw a 1 millimeter polyp, a 1 centimeter polyp, and I have a small hyperplastic change. I don't want him to miss a carcinoid. I will say no significant submucosa. I will say minimal hyperplastic change. This may represent an early hyperplastic polyp. However, if polyp remains of concern, recommend additional sampling. Okay, because it's the classic site for carcinoids, rectal carcinoids and so forth. You don't want to miss it. So, but I'll tell you, I know you saw hyperplastic changes here. When the muscle creeps up, the muscle and the glands are attached to each other. So it will actually pull these glands and change the way they look. Okay, very important to know. It's a different pathophysiology than a hyperplastic polyp, where the glands are growing. Okay, for us here, the pathophysiology is not growing glands, is muscle pulling on it and changing the way it looks. Okay.
Okay.
All right. So we're moving on to the next case. So it is number 26, I think. Yes. Oh gosh. I have 3 boys and they started waking up. So if you guys heard some noises, I apologize. Okay, so what is this?
Is that some kind of, oh.
Let's see.
was thinking of
And,
ripples here, but
go deep here. Okay. Know how long I haven't seen cross sections of colon?
is it a gist or something?
Stomach.
Submucosal, like
Stomach. This is a stomach. Yeah. This is a stomach, oxyntic. You go deeper. You definitely have pathology here. For very, very good. So we walk together. We see that it's a mural nodule. It's in the, where's my cursor? It's not moving. Okay. So it's a mural nodule. And so your classic stains are what?
CD117, dog 1, Desmond.
S100 and Desmond. I would do that. So let's see the case info. Benign spindle cells arising from smooth muscle arranged in fascicles, rarely in nuclear atypia present. Immunoprofile, SMA, Desmond, HCal Desmond, and negative for DOG1 and S100. Diagnosis?
Leiomyoma.
Good job. So now we have a gastric leiomyoma. All right. Oh, well, do you want to see the differential? Of course, it's going to be a gist. So let's see. Differential. The differential for us here is the schwannoma. And gastric schwannoma, you will have more of that lymphoid cuffing or lymphoid areas in it. And it's definitely going to be S100 positive, but I would definitely also do a DOG1 here. But yeah, it looks like more of a schwannoma here. I don't know, I wish I could see nice verruche bodies. Antony A, Antony B, remember? Oh my gosh, I haven't seen that in a while. Okay, so that's the differential. Let's move on. Case number 27. Let's do 30 cases, girls, and then we will move on to some other time.
Yeah, sounds good. Are you available to? Yeah, sure. Are you available either today in the evening or afternoon, or maybe in tomorrow? Are you available tomorrow?
Tomorrow is going
Sunday.
Tomorrow is Sunday. I have to take my son for a picture for soccer, and then I should be available.
What time?
But I can do an hour tomorrow.
Sure. What time are you available?
We can finish the 50 cases. So let's do no, I'm gonna be very late. So let's do 9 to 10 or yeah, 9 to 10 my time. So
that
it's
would
probably
be
12 to 1.
Sure, let's do
Is
that.
that bad for you, girl? Because I don't want to ruin your weekends. We can still do it during the week next week.
No, that's fine. I mean, 1 hour in the weekend doesn't harm our weekend. That's fine.
Okay. All right. So what are we looking at here? We are looking at the colon, and again, and the surface is fine. And I have lymphoid aggregate here. What is that colon keeping from me? Something. So the only two things are the two lymphoid aggregates I see. Okay, let's see if I have spiroketosis at the surface. There you go.
Oh, yeah.
See?
Yeah.
Oh my God, I'm so happy. But
Great.
that's how it is. You miss them because
Oh, wow.
again, these are another hints. The colon is normal. The colon is normal. The colon is normal. So giardia for esophagus and spiroketosis for your colon. Okay. So here, spiroketosis and cause fuzziness at the luminal aspect of the mucosa, absence of inflammatory response. Organisms can be stained by silver stain. I wish they have a nice silver stain. Hi, buddy. So, Omar, this is for you. Omar, this is for you. Yeah, so let's see the differential. Okay, here, there's a new one. The differential is E. coli, colitis, bacterial colitis, and Clostridia. See how the difference, see how it's very, very inflamed?
Mm-hmm.
Yeah,
Yeah.
the colitis, yeah, spiroketosis is not as usually. We do a Steiner stain for again, guys, look at this artifact
Oh yeah.
one more time. Yeah, it tells me that this clinician is getting his pictures from one histology lab. So yeah, so it's just telling you that it's quite inflamed when it is a bacterial colitis. But here you have something. See that pink area? Let's see what that pink area is. It's a little bit of necrosis. Or is that RBCs? RBCs. And then let's go to his dot, the dot sign. I think the dot sign is for active colitis.
Yeah.
Okay, moving on. Okay.
So what? Yeah, nothing.
Go ahead.
Sorry, nothing.
Okay, so case number 28 is another colon. Another colon. What do we have here? It's a little bit more inflamed, but what's striking me here is that the inflammation is creeping into the mucosa. Here you have a little bit of hyperplastic changes. Let's see. Mucosa, lamina propria. Let's see if the collagen band is expanded. Here there is some serration, so I wonder what's going on in this patient. Let's move on. Yeah, there is some serration. Let's see. I actually don't know if he is looking, if that's a polyp or let's see, what does he want us to see? Increased intraepithelial CD3, CD8 T lymphocytes.
Celiac disease. Okay.
Oh my gosh, so it's not even a colon, okay? So it is very, very, very flattened.
Blunted, yeah.
Yeah, see, it's that was very tricky. So lymphocytes and plasma cells at the lamina propria. Complications include an enteropathy associated T-cell lymphoma and adenocarcinoma of the small bowel.
Again, location, right? I mean, they should
I
give the
mean,
location.
seriously, right? But just to be honest with you, I did get celiac disease that looks like that. And I called the lab and I told them, did you switch jars? Honestly, because it looks to me like it's so flat that it looks like a cold, right?
Yeah, yeah.
But you definitely have a pretty much increased intraepithelial lymphocytes right there. See that? Now, I wanted when I was looking at it blindly, I wanted to call this, because of the lymphocytes, that this might be an early lymphocytic colitis, but I did not like the deep crypts. They did not look like lymphocytic colitis to me. So I got mixed messages from this one. Okay, something didn't add up. So that it makes me feel much, much better that this is a duodenum with increased lymphocytes and flattened villi. And it explains the serration, right? It explains why I have serrated changes. It's not serrated changes. It's basically the villi becoming flat, but they did not lose their serration because they are villus, they're duodenal. But some of them are flat, so some of them are entrapped, and you have a lot of lymphocytes in the middle. See that here? Wow, that's a nice classic case. Well, yeah, it is classic. Look at this here. You would definitely call this flattened villi of duodenal, you know, it's a duodenal biopsy. Okay. Another key to you guys that this is duodenal is the Paneth cells here. So it actually makes me feel better. And of course, you have the Brunner's glands. Okay. So always keep an eye, double check, kind of convince yourself or you just confirm location, confirm something. Now I am very comfortable. I'm pretty sure that this is celiac. Okay.
There's this immunoprofile and differential diagnosis too.
Yes, I will go there right now. Immunoprofile tissue TTG, anti-endomesial antibody EMA present in the serum of the patients. I always mention that in my comment and say, please confirm with serological studies, if not already performed, because usually when they have a celiac disease in that bad, the doctor would immediately order serum markers. Patient with HLA-DQ2, 95% of HLA-DQ8, 5% are suspected to get celiac disease. So patients with whatever sclerosing, that disease of the back, forgot what it is, the HLA-DQ disease. Never mind, but yeah, so they will have it more. Differential diagnosis is Helicobacter. Yes, absolutely. So if you have Helicobacter pylori, you will have flattened villi. Okay, you don't need immunostain on this one. These are all Helicobacter gastritis. Okay, but yes, definitely when you have Helicobacter pylori, you can have flattened villi of that, but not as bad as this. But yes, increased intraepithelial lymphocytes and mild flattening of the duodenal villi. Okay, 29, or is it 28?
29.
29, okay, 29. So 2 more to go. 29 is, it's colonic mucosa.
The polyp.
Yes, it's polyp. And now we're looking at I don't want to call this Butzjägers. It doesn't look Butzjägers to me. Inflammatory.
So inflammatory. Just inflammatory.
Yeah, that's what comes to my mind. Inflammatory type polyp or retention type polyp. Let's see. The reason I went up and down, I'm sorry, I didn't speak out loud, is I was looking for dysplasia. So I don't see dysplasia here. No, it's too inflamed, lots of inflammation. Let's see what he thinks. I like to go with the microscopic proliferation of epithelial, stromal, and inflammatory cells in the mucosa. So likely we are going to this. Yes, inflammatory type polyp. Your diagnosis is juvenile, which is my retention type, the one I told you about. But based on the age of the patient, if I have a pediatric patient, I'll call it retention. I'll call it juvenile, and if I have an older patient, I'll call it retention type. Okay, so they're very, very similar. Your retention and your, your juvenile and your inflammatory. Your juvenile is less inflamed. Okay. All right. Now let's move on. Case number 30.
Yay.
And in case number 30, let's go with our checklist. Ooh, any takers?
Oh, wow.
All right. Okay, first of all, let's see the location. Let's look, where are we? A normal what? Normal antrum here. You have IM. Wait, what has it? Wait, what do I look
Small
at? No, this is duodenum. So we have duodenum. We have duodenum. And then we have Brunner's gland everywhere. And then we have neoplasm that is invading. So we're looking at a Whipple case, right? It looks like a Whipple resection.
This resection, yep.
Yeah. And then we have lots of tumor infiltrating everywhere. Look at that. Oh, isn't that so beautiful?
Yeah.
Okay, so classic invasive adenocarcinoma. So let's see. Neuroendocrine. Nice. Why not? Yeah, absolutely. Why not? That's why you have to do stains.
Wow, it looks so much like an adenocarcinoma.
Yeah, it looks so
Yeah,
much
it
like
does.
adenoma. But no, now I can see. See how very small, monotonous glands? Now I can see, but definitely for sure, I can't move anywhere without staining. Look at
Yeah.
that. Oh my God. Look at that. It's in the vessel. Okay, so some momentous calcifications is characteristic. Let's see. Somatostatinoma.
Yeah, that doesn't, we cannot tell that without the stains.
Yeah, we have to do staining, but look how beautiful.
And the-
Classic calcifications. Let's see the immunoprofile. Synaptochromosomatostatin. The differential is, he's saying other neuroendocrine tumors. I would also mention that adenocarcinoma is something that I want to rule out. We've seen that before. Look at that here.
Mhm.
Okay. All right, ladies. Well, thank you for listening. That
Thank you
concludes
very much for joining.
our session
you.
today. I'll see you
Wonderful session.
tomorrow. Huh?
Wonderful session. Thank you very much. I'm glad I asked you to drive, and that was the best way
Yeah,
to go.
I'm sorry it's taking us too long, but
No.
yeah.
Yeah,
All
yeah.
right.
it's-
Okay.
All right.
Yeah, thank you
Okay.
for an
tomorrow.
excellent session, Dr. Gazati. See you tomorrow.
Say that again.
Thank you for an excellent session, and
Oh,
we'll see you
absolutely.
tomorrow.
You're very welcome. I'll try to make my own slides as well to put some, rare and subtle stuff and some bread and butter. I'll arrange something and I'll text you guys. Okay.
That would be
Awesome.
great.
All
So
right.
tomorrow
Have a
9
good
to
one,
10, no?
everyone. Have a good evening.
Tomorrow.
Bye-bye.
You too.
All right. Bye-bye. Tomorrow 9 to 10, na? That's what she said?
That's what she said yesterday.
Tomorrow at 9 o'clock in the morning, 9 to 10.
Yeah.
We can
Yeah,
only do
so-
1 hour tomorrow.
Right. So
Okay.
hour will be 12 to 1, guys. Okay?
Yes. All right. Bye-bye.
Okay.
All right.
Bye-bye.
Thank you.
Thank you. Bye-bye.